Hello, everybody. We are coming to you live from the ADSM meeting in the amazing city of Las Vegas. I'm here with Dr. Kalli Hale and the incredible, I always call you Dr. Solveig. I hope that's okay. We're so excited to have her. She has played such an important role in my life and my clinical practice with the incredible SleepImage rings that we use for home sleep apnea tests, and has talked me off ledges. And I've emailed her many times saying, this is what I see. Is this okay? And we are so excited to have you. Thank you so much for coming on.
Thank you for inviting me.
Yes, absolutely.
Well, Dr. Solveig, why don't you just start by introducing yourself and giving some background about, you're not from the United States, you're trained in medicine, and kind of how you got to all those steps and how you ended up here in the U.S.
Correct. I'm not from the United States. I'm from the most northern part of Europe. I'm from Iceland.
Wow.
And the most northern part of Iceland also,
Wow.
a little town called Akureyri. I graduated from the University of Iceland as a physician. I spent the first decade of my career in internal medicine or hospital medicine, where you do not respect sleep highly. You don't think much about sleep, your sleep or your patient's sleep. And in hospital medicine, you measure everything. After a decade of this part of my career, I went back to training and trained as a primary care physician. And when I started to practice as such, it came to my attention that every third patient in the adult population had sleep complaints. And there was a very high utilization of sleep medications without kind of being confirmed. And as you know, we don't measure anything to diagnose insomnia. It's a clinical diagnosis, but with that said, currently today we know though that many explain their symptoms of sleep apnea as insomnia.
That's right.
So I started to look for something that was simple enough that I could implement into my practice. And at this time, the home sleep apnea testing were coming on the market. But that is not something that you can utilize in primary care because they're complaining about sleep. So I had to have sleep. And during this time frame, I was introduced to a company that was actually started by one of my teachers called Embla. And I invested in this company in 2005 in the hope that I would figure something out, which I did. Because through this investment, I was introduced to a invention from one of our customers, Beth Israel Medical Center in Boston. There is an amazing physician there, Dr. Robert Thomas, a neurologist and a sleep specialist. And he had this idea about utilizing cardiopulmonary coupling for sleep.
Yeah.
And we decided to license the technology. I was still working in my practice. I was not working with the company. And there wasn't much happening in the development of CPC until in 2014 when we had sold the company Embla. And then I came on board and started to work on the development of the technology. After I started this process, I went and got my sleep training. So I have a master's degree in sleep medicine from Oxford University, where I focused on sleep in children.
Amazing.
That's awesome. So, in the company that you work at now is called SleepImage.
Correct.
And you're the chief medical officer?
Sure, yeah.
Yeah. And first of all, the SleepImage ring, we use, what do we have, like 200 of them?
Probably.
We use this all the time. We hand it out. And I think one of the things that is, one of the things that has set us apart as a company, as people in healthcare, as a community involved center is we're really passionate about the diagnosis side of sleep apnea. And Kalli has a really famous saying, and it's, I don't care if you let me treat you, but you need to know. And so the rings have been so easy to use. It's so easy to explain the use of a ring to a patient. It's so easy to get support from SleepImage too. So I want to touch on this just a little bit because it's not meant to be like a commercial for SleepImage or the Ring, but we're power users of the Ring. How many sleep tests do you think we do a week?
I mean, I don't know. I feel like I've looked at over 1,000 in the last few years. I mean, it's amazing. And in dentistry, it's so hard to make sure that you have products like home sleep test. There's so many different home sleep tests on the market with many disposable parts, and it's all very complicated. And you guys have it figured out. I mean, it's absolutely stellar.
You must have practiced.
No, we didn't.
One of the idea about the SleepImage system is that it had to be very simple for the provider.
Yep.
It has to be very simple for the patient to understand the output. That's the image, the sleep image, where you can show a person their output, and you can show them when they have poor sleep, when they have apnea. So you have something to talk to them about. But also, I'm from Northern Europe, and we are very sensitive to global warming, not utilizing too much of anything that we don't need to use. So that's why it was very important for us. If you think about the home sleep apnea testing we were selling, the Embletas, there was a lot of consumables.
Oh, I'd never heard of it. I didn't know.
A lot of consumables that went straight to the trash.
Right.
So if you really are going to address this high prevalence of sleep apnea in all age groups, maybe not in teenagers, but in children, the prevalence is really high. And then after middle age, it gets higher and quite high. You have to have something that is easily implemented because you can never have enough sleep physicians to see all these patients. So that was the idea behind this simple system. And also, if you have something that is very expensive, the practice will be stuck with very few devices.
Absolutely.
So there is a very long waiting list that will pile up, and you will not be able to service your community of patients or people.
And just on the no consumable side, it's really great to not be creating trash, but from like a business operation standpoint, it's great not to have to carry inventory.
Yeah.
Yeah.
These are in really small boxes. The instructions are very simple. And I love the SleepImage Ring because it makes my job really, really easy because it's how can we just hand out the most sleep tests as possible? And there's no cost to it, or very minimal cost to us. And it helps us fulfill our mission. At the Airway Dentist, our mission is to rid the world of sleep disorder breathing. It's a really big one. And if we're charging an arm and a leg for a sleep test, then we're putting up a barrier that doesn't let us have the conversation with the patient that the patient needs to know.
Yes.
And so, so thank you for developing this wonderful,
yes,
wonderful
we're
thing.
very, very grateful. And, I have I pride myself in feeling like I really understand the data that comes out of that. And I don't know if I've ever told you, but when I first got it, I spent hours reading the user manual because I was like,
I actually have to comment now because I get a call from a person that I know that says, "Can you talk to Kalli Hale?" And I'm like, "Yes, sure."
Oh my gosh!
And so I even remember this was Friday, and so we connect over the phone, and she says, "So can you please explain the sleep apnea indicator and cyclic variation of heart rate to me?" And I was like, "Oh my God, wow, she must have been reading." Because
I really just knew that patients were going to ask me. They were going to challenge me in some way. Do I know what I'm talking about or whatever? And I just was like, because I knew that this was the key to me helping them. And if I didn't understand how to explain that key, I was going to fail them. And then I remember when Vivos had me in Vegas, that was the first time we'd interacted really like in person, and even your husband were there, I believe. And I just spent so much time trying to explain the SAI score in layman's terms, like, this is what you need to say. This will help them to make sense. And it meant the world to me when you guys came up to me afterwards and said that I said it right and I did a good job. Because I was like, yes. And I still have that picture somewhere. I'll have to get it to Wee so he can put it in this, because I have the picture of the three of us in Vegas, like however many years ago that was. So, yeah. But I loved you telling us earlier before you're on the your heart for the prevention. So at the Airway Dentist, I mean, we are starting at babies, newborns, frenectomies, consults. We start oral appliance therapy as young as 3. And I never really knew that that was part of your focus. So this is great for me, because I just figured, we're looking at sleep studies, no matter the age, but the ability to, just like Dr. Peter Sicily was just talking about when we listened to him, the ability to prevent this from ever being a problem in the first place is a huge, I would say, burden on dentists to pay attention and figure out how to treat it. But it's such an important thing that I'm finally hearing at the ADSM, because that has not been the message for years. Last year they did the big pediatric debate day. I don't know if you were here that day or not, but it was Audrey Yoon was up there talking about, her side, and then they had an opposing side, and it was like, it was wild. It was
Dr. Gozal was here as well.
Yeah, Gozal was here talking about the neuro impacts of hypoxia in kids and all of that. And for this year, for that doctor to come up and ask him that question in that part, because that was just a little part of his whole talk, I was like, yes, are we all paying attention now that, like, maybe we just prevent these patients from ever needing a CPAP in the first place if we can?
Yeah, and also because when we are very young, little, that's the time when our brain is really growing. So if the dentist pays attention to the pediatric population, you can make a major change in a young life. Because if they're not sleeping, their brain is not growing. And the problem is that a child will not show up sleepy and be falling asleep during the day. They will just act out, and they are difficult and they annoy everyone. But not many start to think about maybe the child is not sleeping. So I think if we can make awareness of sleep in children, and if we can have some focus on, so we have growth charts. We physicians, we're really good with the growth charts. We stare at them diligently while we are looking at children with some problems. But we never think about a sleep chart for a child. Wouldn't it be great if you had on the growth chart a expected value of sleep quality for children?
Absolutely.
Yes. This is something that I've said a lot is in public school, you get screened for scoliosis. And I would bet everything I have at my house that the prevalence of sleep apnea in kids is immeasurably higher than the prevalence of scoliosis. But man, they check you every 3 years or whatever it is. I mean, I think it's 4th grade or 5th grade, they check you for scoliosis. If we just screened for some sort of underdevelopment, or with a questionnaire that went home with the parents, something really simple. But
and this is a very interesting comment, because when I started my master program, I wanted to understand sleep in children better, and I was asking all the professionals about prevalence of sleep apnea in young children, and everyone referred me to the same paper, and the number was 1 to 4%. And
oh my gosh!
Like, I don't think this makes sense. So I did a systematic review where the number was quite different. But the problem, what I found in the literature, is that almost all of the studies are done just by questionnaires. And we all know how that is. And there are systematic reviews on when they compare questionnaires to a PSG, polysomnography. So we did a study in my little town, Akureyri, which is now under review. Good. And we published the poster at the World Sleep Congress in Brazil. Amazing. And the number that we came down to was 22%. So that's very far from 1 to 4.
Absolutely.
What were the age range?
4 to 8.
Wow.
So it was young kids. Yeah.
Oh my gosh.
So this is very high prevalence that that it really is needed to pay attention to, because this is the time in your life when your brain is really, really growing.
Absolutely.
And also, if you don't sleep, your body will not grow either.
Right.
So I think it's a merit to incorporate sleep into pediatric care.
Yes. And to understand the orthodontic component.
Yes.
I mean, if the pediatricians were screening more for it, that would be great too. But all too often, I still see little kids getting put on CPAP. And it's, I mean, if you have no other solution, I understand. But as far as mid-face deficiency, with the pressures of the mask on the wrapping around the back of their skull, you get the headgear effect. And so that's where I want them. I just want to spread the message of what we can do with early intervention orthodontics and, you know, these habit corrector appliances, because they're literally changing the way the kids breathe.
And they're also low cost interventions.
Yes. No kidding.
So low cost and zero consequence.
Yeah.
Unlike a surgery. So
Right.
So we're here. It's day 2 of the American Academy of Dental Sleep Medicine, and when we were getting ready, y'all were talking about the speaker you just listened to. What was it about that speaker that?
Go ahead. Okay. Well, I want you to talk about your what we were talking about down in the elevators too. But he came on and he was showing the efficacy of oral appliance therapy, basically a mandibular advancement device, and CPAP, because the general medical community would say CPAP only. It's the only thing that works. These dental appliances don't work or whatever. And he totally disproved that.
So that was quite an interesting move. So Dr. Sestouli has, for the past decade, been a proponent of utilizing different types of therapy, not only focusing on CPAP, but that we have multiple types of therapy. And he, in his talk, he showed us a number of good studies where because one of the things was that the mandibular advancement devices, they wouldn't have the same effect as CPAP. But he showed us he was focusing on cardiovascular risk, and he showed us that they may even be better than CPAP. So
Wow.
He did.
I think it will be difficult for us physicians in sleep to say they don't work. And also what he showed, people stay with their therapy both on days and longer over the night. And that must be the key, to have therapy throughout the night. And as he mentioned, and we all know that sleep apnea is more higher in REM sleep, and we have more REM sleep at the end of the night. So it's not good if we only use our CPAP for 2 hours and then...
Absolutely.
Yeah.
Well, what is considered as a full night's sleep? Is it 4 hours?
With a CPAP?
With a CPAP?
With a CPAP,
That's
yeah.
considered one night?
Yeah, that is, if you
crazy.
use for 4 hours, that is checked as a full use of your CPAP.
Do you feel well when you sleep for 4 hours?
Horrible.
Horrible. Well, he also talked about the cardiovascular risk on I think he said less than 7 hours actually in his talk today. What the cardiovascular risk was, it was 3 to 6 times higher chance of having a cardiovascular event if you slept less than 7 hours a night.
Wow.
Yeah. So absolutely, yeah, he did a great job. And I very much appreciated that content. You know, we see it. I've done enough oral appliances that I'm like, I know they work. By golly, I don't care what anybody says. Like, I'm going to say that we know they work. But we need this evidence. We need what he presented so that more people will do it, and less people can be naysayers about what we're doing. It's really tough in dentistry. I mean, it's really tough to get anybody to take you seriously in the medical community sometimes in regards to sleep. And I mean, when I started this really almost 8 years ago, the target on my back in our town. I mean, any sort of early intervention pediatric, you're going to use an appliance on a 3-year-old. I mean, I had a whole bunch of really upset people in my town that I was doing that. I cared, but I didn't care because it was what was best for the child. But having more evidence like this for us is only going to help these dentists that are like, I'm scared to do this. I'm afraid I'm going to hurt them. I'm going to get in trouble. The board's going to come after me, whatever. No, you can do it. You're going to help them. And so it's really good that we had that.
I just think that what Peter Sestouli was doing, he was building a bridge between the two communities. And if we are going to be successful, we have to be able to communicate. We have to be able to focus on the patient
Yes, absolutely. What's best for them and their needs, and work together.
The focus on the patient is, it's what, when I see negative comments about our practice or about Kalli or about what we're doing, because there's a lot of that, much less than there has been in the past. I think
We
the
have great
last
Google
few-
reviews. Our patients love us, so that's good.
Yeah, and we really, we're a family of dentists. So both of her parents are dentists, and one thing that's always been driven home for us is it's a very patient first practice that we have. And so sometimes the right thing to do for the patient isn't to stick them with a really big bill and a treatment plan that's, it's exactly like how the dental school would want. I think it's really important to meet patients where they're at. And because some care is always going to, in my eyes, is always going to be better than no care. And the nice thing about the pediatric sleep component that we do, even the adult sleep,
Yeah.
it's not tens of thousands of dollars. And what's even crazier is the kid stuff that's very, very cheap. It works. And y'all were talking about the cardiovascular component. 2 years ago was it a year ago, we were in Puerto Vallarta.
Oh, it was at least
2 years ago.
At least 2 years. Yeah.
Paul Wynn was speaking about the importance of the cardiovascular risk after someone's had a cardiac event, and that for cardiologists and surgeons, their performance is measured by how soon a patient who just had an event and was treated, how soon they are readmitted for a similar thing or associated thing. And there's I can't remember the stats, but there's a gold standard. Let's call it like within 61 days. If it's under 61 days, it's a bad thing for that physician. But if it's on the 61st day, it doesn't reflect poorly on the physician.
Yeah. I think it was 30 days, but I could be
was it
wrong.
30?
Yeah. But he was like, we can lower the hospital readmissions
Yes.
rate.
And that, well, let me just finish, because that made me, at our dental practices, every time you walk in our door, we take your blood pressure. And when you're with us for ortho or airway, that's a lot. You come in a lot. And so we have 10 years of blood pressures twice a year or more on every single person. So you just look at it over time, and we found one patient, and it's a guy, I grew up with his kids. We went to church together, and his blood pressure, severe type 2 or severe 2. I mean, he was like 170s was normal. 170 over 110 or 100 would be normal for him. And I think in dentistry, we are pretty numb to hypertension, but that was a lot. And it was about 2 years after treatment, you could just see a 24-month difference where he went down to, I don't think it made it all the way down to like a pre-hypertensive status, but
No, he did. He went down to like 129 over 80 something with being treated with oral appliance therapy.
yes. And that's, and I love that this is a single anecdote because that guy, he loves what we did for him.
Yeah.
He loves it, and he feels better. He looks better. He looks like a better looking younger brother version of himself.
Yeah, so blood pressure is really important, and we could change that too.
And that is a very easy measure
Yes.
to track therapy.
Yeah.
If they have high blood pressure and you start therapy, you can track impact of therapy by measuring their blood pressure. And especially if they're on medication, you can cut down on medication. That's really great.
Yes. Oh, absolutely it is. Yeah. And we were actually talking earlier too. I got up and asked Dr. Peter a question at the end because everybody, I feel like right now is talking about hypoxic burden versus AHI. So that when you're treating the patients, you got to lessen the hypoxic burden. And I've dug around and I've looked in the literature and I'm like, but what does that mean? Like, how do we lessen it? What am I trying to lessen? And so I got up and asked him, I said, am I trying to raise the lowest SpO2 up, or am I trying to raise the average SpO2 up? And unfortunately, we don't know yet. We don't know how to measure what it is
So
that
we're
they're
talking
saying.
about this thing, and we don't know what it is yet.
We don't know how to measure it yet. Would you agree?
So we have this area on the curve of SpO2, which we can look at. And there are some publications that have talked about the hypoxic burden. Like Dr. Sistuli pointed out, there are more than one method to look at. But
Yes.
I think the key is that we have the AHI. We all constantly talk about AHI, that it's not a very useful maybe measure, but it is a measure, But the key is to look at all the measures.
Yes.
And that is why I was so intrigued when you asked me about the sleep apnea indicator that is in our system, because that is measuring the effect on your cardiovascular system.
Yes.
It is measuring the cardiac reaction to your apneas.
Yes.
So I think we need more than one measure.
We do.
I have been very outspoken about sleep quality, and we have published quite a few papers on that. It's not enough to improve the AHI.
Right.
You have to improve both the sleep quality and the AHI if you're going to improve blood pressure, for example.
Yeah.
Same in kids if you're going to improve behavior or their cardiovascular and metabolic metrics. So the more metrics we have to evaluate the disease in the beginning and outcomes of therapy, the better for the outcome of the patient, I believe.
Absolutely.
So hypoxic burden is just one of these metrics, but we need to expand. And everyone agrees that we need to expand a little bit out of the AHI.
Yes, for sure. And I do, the doctors that I mentor, I do tell them the same thing. Like there's still going to be a win in this case, aside from the AHI, let's find it, and we're digging around in the sleep image reports. I mean, everybody that I mentor uses the sleep image rings because I'm like, these are the ones that you need. But, it's difficult in dentistry because we are so used to black and white. We're used to the crown margin seats or it doesn't. The filling is sealed or it's not. And sleep is so different. Dental sleep medicine is so different from that. And when we're titrating specifically the wins in the case and is this good enough and whatever, he made a good point of you've also got to go with the patient's symptoms. Are they snoring less? Do they feel better? And I'm like, yes, I know, but I like numbers. Like I want to know. But I do have a habit in y'all's reports that I basically skip the AHI, go straight to the SAI score, which I've renamed the heart score, just FYI. It's the heart score. That's how I say it to patients. I think it's easier to explain. And I go to the lowest oxygen. I'm like, okay, what happened? And then we're going, we go from there. So what else?
Those are acronyms I don't know.
Oh. I just hopefully it expresses the people listening that are using that those are the metrics that I think are so valuable in the sleep image report. And it used to be up there by the AHI.
Not everyone loves the
why? Can you tell me why?
I think it's because it's a metric that isn't commonly used.
Okay.
And not everyone is as interested in extra metrics, like the sleep quality index, which I love.
Yes.
Because if you think about it, I'm sure you have seen a lot of kids that a mom has complaints and mom is adamant that her child has sleep problems.
Yeah.
And you do multi-night testing and you don't get the apneas that you're expecting, but the child has very low sleep quality because there is a lot of fragmentation.
Yes.
And that will tell you this child has a problem,
right,
because healthy, happy children have good sleep quality.
Yes, they do. Wow.
So that's why I like the extra metrics in the system.
Yes.
Because it helps you in the evaluation of the patient
as a whole.
All patients are not the same,
right?
And they present differently, and it gives you like the image of sleep. That was very helpful for me in the beginning.
Yeah.
Was to look at the image of sleep. Here you have one image or one night of sleep,
right?
And when you're not sleep trained,
yes,
for me it was very helpful.
Yeah.
So, the image of sleep from SleepImage.
I love it.
I love it. When changing subtopics just a little bit, but in dentistry, Kalli was saying how there's a challenge because of usually it's specialists that have an issue with what we're doing. And then last year we heard Dr. Kozal talk about the potential developmental deficits that you'll never know were a deficit because the child never developed to their full potential. And so if 24% of children have this between 4 and 8 years old, like you're proposing, which I believe, I mean, you look at the underdevelopment, the widespread underdevelopment of the face, it's surprising. I'm surprised it's not higher, but dentists are doing a really good job, especially airway dentists, about eating themselves. There's a lot of what I see like infighting between, I would say the people
Treatment
on this
modality.
side of this side of dentistry, which I believe we're on the best side of dentistry. It's very rewarding. The patient testimonials just make it so much easier to go to work. And but sleep dentist to sleep dentist to sleep dentist, they're arguing. They're arguing about what appliance to use. They're arguing about how to use the appliance. They're arguing about, when to use it. They're arguing about how to bill patients. Insurance, myofunctional therapy or no myofunctional therapy, and all these things. And we've incorporated everything into our practice. We are 100% multimodal. You could come into our practice, 10 different patients could have 10 totally different appliances and treatment plans. You talked about in the AHI being the gold standard for a while. On the side of medicine, what are your colleagues doing? Or do you feel like medicine is doing a little bit of the same thing, or is medicine progressing forward faster than you thought or slower than you thought they would?
I think we have exactly the same problems as you were describing. There is not agreement of everything, but I think we just have to focus on the patients.
Yes.
If you help a person to optimize their prospects in life, like for children, can that be a bad thing to do?
No.
Never. Oh, I love it.
Last year in New Orleans, Gozal gave this awesome 2-hour lecture about. I mean, you could feel his passion, and he's backing it up with loads of research. Every single slide was a new study.
There's no denying this.
And I don't, I'm not trying to point fingers at an entire specialty here, but because I think the ADSM did a really good job setting up like a point counterpoint on their pediatric
For the debate.
day.
Yeah.
And the orthodontist got up and said, yeah, well, wait till they're like 9.
Yeah.
Wait till they're 10. Wait till these teeth are up. And you just play the tape back for 30 minutes and you see Gozal showing you that, there's irreversible damage that has already happened.
By the time they're 3.
And so, why wait?
Yeah.
And so.
You absolutely should not wait, because when you're 9, your brain has pretty much developed, not fully, but there isn't too much room left for growth and development. The key years are when these kids are little, and I don't know which papers Gozal did refer to, but there are plenty of papers, and there are very good recent systematic reviews that have looked at all these papers, and they are absolutely clear that you need to treat these children when they're young, not when they're starting their adolescence years.
Absolutely. Yeah, absolutely. I knew we would agree on that, but it's nice. It's nice to hear it from you too. Wow, this has been awesome. I really appreciate you coming on and chatting with us.
I do so much. Kalli and I started this podcast so that we could have some marriage counseling, and it's worked really well for a couple of years.
Yeah.
We'll wrap it up here. Is there anything you want to, any closing remarks you'd like to offer?
Yeah, my heart is in sleep in children. I really, really would see pediatricians step up like the dental community has done, and incorporate sleep into routine pediatric care and identify these kids and help them. If you think about it, it's not only the sleep apnea, it's also if they have poor sleep routine, you can help them. If they're not sleeping sufficient hours, you can help counsel the parents how they can implement good sleep habits, because this is not something that you do when they're 12. You need to do this when they're young. So I encourage the healthcare world to focus on the kids, to try to make them healthier and happier and have better prospects. And you can do that through sleep.
Well, thank you. You're so right. Your contributions, if they ended today,
would be massive.
The sleep ring is it's amazing. And like I said, we're power users. We have hundreds of them. We test as many people as will let us. We'll grab their finger and put it on for them. So thank you for
so much
what you've done for us in our community so far. So thank you.
Thank you. It was good to see you again
Good.
after all these years.
Yes.
All right.
Awesome.